Okay. Hi and good evening to everyone. My name is Pamela Mann and I support student and resident activities here at the Academy. I am delighted to welcome you to our weekly community conversations. Tonight's topic is the resident poster contest. And we are joined by our foundation board president, Dr. Marianne McKennett, who will be moderating tonight's session. Before we get started, I want to encourage all of you on the live stream to add your questions in the comments section of the chat. This is a very interactive session tonight, so we really encourage folks to submit their questions as it's a big part of tonight's activity. We are also we are pleased to offer one AFP prescribed credit for this live event. So please claim your credit at the website link that's listed on the slide. And we'll also include that link in the chat for you to grab later. And finally, note that no identifiable patient information was used for the research projects or case reports. And now I'm going to hand it over to Marianne. Marianne, the floor is now yours.
Thank you. Hello, I'm Marianne McKennett. I'm the president of the CAFP Foundation and program director for Scripps Family Medicine Residency Program. I'm very happy to be with you this evening moderating the resident poster contest. And I want to thank everyone who's out in Facebook Live for joining us on this Sunday evening of the Memorial Day weekend. Usually, this is an in-person event that takes place at our CAFP Clinical Forum, but even though we can't all be together this year, we're very excited to improvise and still bring you the resident poster competition on Facebook Live. First, I want to give an enormous, big, huge thank you to our CFP staff, Pamela Mann, who's my co-host for the evening, Shelly Rodriguez, who keeps us all on track, Morgan Cleveland, who's going to be very important today in the judging, and Josh Lunsford, who is organizing the Facebook Live and also has put together an online exhibit hall for us. So tonight you'll be hearing both research and case presentations from 10 residents representing our California Family Medicine residency programs. As Pamela said, this is an educational and scholarly activity, and we are very proud to be presenting this now in its 7th year. This activity helps our residents meet their ACGME milestones for scholarly work, and it's sponsored by the CAFP Foundation and made possible with member support. So just a little bit about the contest itself. In late fall, family medicine residents were invited to submit case and research abstracts that underwent a blinded peer review process. This year, there were 19 resident posters that were accepted to be part of the contest. These submissions then went through another round of review to determine which posters would be presented during the live presentation tonight. And these are the 10 residents who are here with us this evening. So they are already winners in every sense of the word, but there will be 2 ultimate winners tonight for the top presentations, 1 case report presenter and 1 research project presenter. These will be announced immediately following everyone's questions, and we're delighted to be joined by members of the foundation board who are serving as our judges. And at any time later, over the weekend, next week, you can view all 19 posters by visiting the online exhibit hall at our familydocs.org site. So now on to the fun of the evening. This is a 2-slide, 2-minute, 2-question format. Pamela will be keeping time and I will be moderating the questions. If you have a question, please type it into the comments box in Facebook Live. And I would just suggest that go ahead and add a question as it comes to you during the presentation. And the first 2 questions from any on any presentation will be given to the presenters. So if everyone's ready, we will get started. Our first presenters are Legina Scott and Tricia Valenzuela, representing Family Health Centers of San Diego Family Medicine Residency Program.
All right, so the title of our research, as you can see, is Missed Opportunities Improving Same-Day Control Initiation Using the One Key Question Method in an Urban Underserved Population Community Health Center. Next slide. So some background, the average American woman will spend about 4 years trying to get pregnant, but she'll spend 25 years trying to avoid pregnancy. And according to the US statistics in 2011, 45% of pregnancies in the United States were unintended. The CAFP and the Interstate Postgraduate Medical Association recently created the Reproductive Healthcare Initiative to improve women reproductive healthcare at a clinic level using the screening tool, the One Key Question. It asks, would you like to become pregnant in the next year? Our study intended to prove same-day birth control initiation rates using this One Key Question screening tool. And we asked it at all clinic visits for women of reproductive age. Our initial cycle to remind providers to ask this question included prompts on computers, on individual computers, and we posted a quick start algorithm for easy reference. Our second cycle added an addition of prompts into individual patient out guides for women of reproductive age. Next slide.
So unfortunately, our interventions did not increase the same-day birth control starts compared with our baseline. However, we did see a 10% increase in asking of the One Key Question and a 2% increase in the same-day birth control initiation rates between our intervention cycles, which is figure 3. Also surprisingly, 20 to 30% of those asked who did not desire pregnancy preferred abstinence or chance rather than starting birth control. So this is another area of future exploration of how health literacy and cultural influences, among other social determinants of health, likely play a role in our population's reproductive health choices. And finally, about 60% of eligible women were not asked the One Key Question. About 25% of these women were seen for an acute care visit. So oftentimes reproductive age women are not only routinely seen for well woman exams.
Okay, you've reached time.
Great. Well, thank you for your presentation and excellent references. And we are going to be looking for questions here from the audience. So here's a question. What is the number of providers who saw the 100 patients? So approximately how many people saw those 100 patients?
So it was in our residency clinic. So we have like 18 residents in our clinic plus all of our faculty members. So that was generally about the group that saw these patients. Another
question. I thought it was interesting in your presentation that there seemed to be a difference between acute care and perhaps routine visits. And I was wondering if you had talked about ideas for addressing those missed opportunities in the more acute visits, similar to what we think about with immunizations.
Yeah, I think there's just some, providers in an acute care visit are very focused on one thing. It's a very focused visit, of course. And so I think just changing provider ideas about knowing that this person may, this patient is a young, healthy woman. She may only be coming in for this one time throughout the year. And so it may be a pretty important opportunity to just discuss birth control at that and pregnancy desires in those particular visits as well. And that would greatly probably increase our coverage.
Yeah, so knowledge is power, and we thought just by letting providers know about this disparity, it would make them more aware of it and more aware that they need to ask these questions during these acute care visits.
Excellent, thank you. Thank you very much for kicking off our presentations. So next, I'd like to introduce Abraham Vela and Jesse Chung from Pomona Valley Family Medicine Residency Program.
Hello. So today I'm going to present an OB case, and it's about a rare thromboembolism in a high-risk pregnancy. Next slide, please. So our patient is a 39-year-old G1P0. She had an uncomplicated prenatal course and presented to LND with contractions at 38 weeks and 3 days. Unfortunately, her labor was complicated by a prolonged second stage of labor and failure to descend, which required us to take her to a C-section. Post-operatively, she developed a fever due to endometritis, which resolved with antibiotics. We also started Lovenox due to decreased mobility. She was discharged at around post-op day 6. About a week later, she presented with oozing of blood from the incision site, and we admitted her for overnight observation with IV hydration after we ruled out a wound infection. 2 weeks afterwards, she came in with an upper extremity mass that was painful. Imaging found to show a 4 to 5 centimeter supraclavicular mass and extensive DVT highlighted here in the image. Hypercoagulable panel for her was negative, and we initiated treatment with therapeutic Lovenox, bridged her with warfarin for about 6 months with an INR goal of 2 to 3 per hematology recommendations. Next slide, please. So here are some of the risk factors present in pregnancy in itself, and highlighted are some of the risk factors in our patient, which included a C-section, and BMI for her was actually of 28, advanced maternal age, and a postpartum infection. It is also found that 70 to 80% of upper extremity VTEs are due to intravenous catheters, which was also present in our patient. I included some anticoagulation recommendations, which include to start heparin with pregnant ladies going to C-section if their BMI is over 40, and of course SEDs for all patients until they are ambulatory. Next slide, please. Currently, our patient completed about 6 months of warfarin postpartum, and the follow-up ultrasound actually showed that she continues to have a chronic deep vein thrombosis and was transitioned to Xarelto, currently being evaluated by vascular surgery for possible thrombectomy.
Give her hand, great, you've reached time.
Excellent. Well timed and very interesting presentation.
Thank you.
So we have some audience questions. So here's a question. Was the patient's arm assessed prior to hospital discharge? And did she have any evidence of arm swelling at her IV or IV site swelling or redness prior to discharge?
Excellent question. And yeah, it was assessed. She was not complaining. There was no erythema present. IV was removed prior to discharge. And there was no pain or signs of infection at that time as well. Yeah.
Thank you. I have another question. I'm wondering what recommendations you would make to this patient for future pregnancies.
Thank you for asking that. Something that I think it's important to note that the biggest risk factor for a VTE is having a history of a VTE. So her next pregnancy, besides all the other risk factors, her biggest risk factor is that she already had one. So there's a lot more studies that need to be done. There are no clear guidelines that we have. The ones I listed are some of the recommendations from ACOG. But because of her high risk, she should definitely be considered for anticoagulation for her next pregnancy.
I appreciated the tip for low molecular weight heparin for women with a BMI over 40 too.
Yeah, yeah.
All right. Thank you very much.
Thank you.
Our next presenter is Matilda Fredrickson from Stanford O'Connor Family Medicine Residency Program. Welcome.
Hi, everyone. My name is Matilda Fredrickson, and I'm a family medicine resident at Stanford O'Connor, and my project was a psychoeducational intervention for Spanish-speaking patients. During my residency, I noticed that many of my Spanish-speaking patients with depression had difficulty starting antidepressants and attending therapy. So I decided to interview 9 patients with depression to assess any barriers they were having. From the results, I decided to create an intervention to address these barriers. The psychoeducational intervention was a 90-minute group class, which consisted of 3 main categories. The first was educating patients about trauma-informed care. Each patient had the opportunity to assess their own ACE score and discuss acculturative stress. They were also taught about toxic stress and the effects on mental and physical health. This allowed patients to become more aware and more compassionate towards themselves. We then discussed specific cultural barriers, such as fatalism, familism, and perception. For example, fatalism is the belief that they don't have any control in their future, over their future. Finally, I was able to discuss the options to treatment more extensively and answer questions. The way I carried this intervention was that I received a list of Spanish-speaking patients with depression, and I called them and invited them to the intervention. I held the intervention at 3 different clinics: my residency, continuity clinic, and 2 other clinics, an FQHC and a free clinic where I had no connections with the patients. After the interventions, they received a folder of resources and they were offered a one-to-one consult if they were interested in starting medications. They were followed after 1 month after starting medications, and then at 3 and 6 months. Next slide. Post-intervention, patients were more likely to start medication, exercise, and meditation. This was true in my continuity clinic and other clinics where I had no prior connection. Unfortunately, there was no increase in therapy. I only had 2 patients that attended therapy but stopped after 1 session. Next slide. My final thoughts are that outreach is very important because many of these patients are not going to seek therapy for their mental health. And there is very low significant rates in patients attending therapy. I believe that it's important for providers to be aware of the barriers that these patients face in order to successfully treat them for their mental health. I look forward to conducting more sessions.
Great.
Thank you very much. What an important topic. Excellent. We have a question for you here. What question or questions did you ask to assess fatalism in your 9 patients?
When I addressed fatalism, I explained to them, what fatalism is. And it was amazing having this in a group class setting because instantly people were talking about how this is so true in their culture and in their families. And then that led to other people talking about, how ingrained this is in our culture. So I think me just opening up the conversation of fatalism and people hearing their own experiences really kind of make them have the sense that, we do have this and we don't necessarily have to feel this way, that they can have control over their futures and they can, seek treatment and not feel the way that they feel.
Thank you. And how this is such important work, how would you spread the work of this study?
So I actually have been in the radio to discuss trauma-informed care to reach to the Latino community about how important it is to seek help and to seek treatment options. And I plan on doing this, more at clinic settings. I would love to collaborate with other clinics as well, if anyone's interested.
Thank you. Really good. I was wondering if some of the patients might have stayed in group therapy. So another thought. Really excellent. Thank you. Thank you very much. Okay. Our next presenter is Timothy Vu from Riverside Community Hospital, UC Riverside School of Medicine, Family Medicine Residency Program.
Thank you for having me. So my presentation is the next pulmonary complication of vaping use with pneumomediastinum in a young male. Next slide, please. So my case involved an 18-year-old male with generally healthy who came in with altered status. So he was alert and oriented when we were talking to him, but prior to the events leading him to coming to the hospital, he didn't really remember too much going on. But he had a CT of his neck, of his head, that showed no intracranial findings. But then they saw some subcutaneous emphysema of the neck that kind of let down, which caused them to do a CT of his chest as well. And they saw some ground gas opacities and extensive pneumomediastinum. He was just on 2 liters of O2, but that was quickly titrated off. He had some crepitus notice on the left side of his neck, tracking down to the left side of his chest wall as well. And then you hear a crunching sound on auscultation of cardiac auscultation, but otherwise generally pretty benign physical exam. Next slide, please. So the imaging is pretty interesting. On the right-hand side, you can see the chest x-ray that we took, and you see a air silhouette kind of around the cardiac silhouette. And then on the 2 CT images, you could see air going around both like the thoracic aorta and then the cardiac silhouette as well as the extensive pneumostinum. Next slide, please. So luckily, this patient ended up doing well. We just had him on some antibiotics conservatively and did an esophagram that kind of ruled out any esophageal rupture. And then he was just monitored and did well and discharged on the 3rd day. So this case is more of like a cautionary tale just that we don't really know all the effects that the vaping is doing to our, especially pediatric young adults, with all the different kind of flavorings, additives, how they're aerosolized.
Tim, you've reached time.
Effect are on the lungs.
Thank you for that very interesting presentation. See if we have some questions from the community. Here's a question. You mentioned treatment with antidepressants being initiated, but what assessment or intervention was done for the polysubstance use, such as the marijuana, cocaine, and Xanax?
In this case, kind of just talked to him a little bit more to see if he had a primary care, which he didn't, and try to get him back into our clinic just to have a little bit more extensive conversation about, what, the dangers of it. He had a pretty extensive kind of prior history of family kind of trauma. So let's kind of diving a little bit more into that and seeing what we can kind of do and help him with his use.
Thank you. I also was wondering what was your what other causes did you consider before getting to the vaping as the etiology?
Right. Yeah, because other causes, we're wondering if there's any trauma, and he didn't really have too much of a history because he didn't really remember what happened. Mm-hmm. But as far as we could tell, there wasn't any sign of any blunt trauma or anything around the chest. And then we had pulmonology, the CT surgeons. It didn't seem like there's any other cause besides the vaping. And then we did a urine drug screen as well, and they didn't see any of the benzos, any other kind of substance use besides just the marijuana.
Thank you. Thank you very much. It's certainly going to be important to make sure that vaping is part of our social history, right?
Yes.
Good. Thank you.
Thank you.
Okay, our next presenter is John Tran from the UCLA Family Medicine Residency Program in Santa Monica.
Hello, everyone. So during my intern year, I had the privilege of creating the Bruins and the Bees program, which is a sexual education curriculum for high school students. Next slide, please. So my curriculum consisted of a 1-hour lecture where I would provide clinically relevant counseling that I would typically do as if I were in clinic. For my project, I learned that high school students may benefit from sexual education by clinicians in a school setting. One word I want to emphasize is clinicians, because an overwhelming majority of my students prefer to receive sex ed from doctors and other medical providers, but in reality, they don't. They get it from their parents or teachers. Looking at the graph using a survey before and after my 1-hour curriculum, I found that for the top 2 graphs, intent to use condoms and contraception increased. Looking at the bottom 2 graphs, my Bruins and the Bees program increased perceived knowledge about sexually transmitted infections and condoms in adolescents. Next slide, please. And the first discussion point I want to make is that family medicine providers play such a huge role in educating adolescents about sexual health. In reality, with 1 hour in clinic, I only have time for 2, sometimes 3 well-adolescent visits to counsel them. Compared to 1 hour in the classroom, I have the opportunity to impact over 30 students. The thing is, most of these sex ed interactions and interventions at schools are run by non-healthcare providers. For example, teachers can talk about what is in a birth control pill, but we as family medicine providers can counsel about clinically relevant information and how to properly use birth control pills. So we can really engage schools and make a meaningful community impact as family medicine providers. Next slide, please. And for future directions, we just need more intervention programs, but in reality, we also need more family medicine physicians to go to the local high schools in the community and teach about sexual education. Thank you for listening.
Great job. Right on time.
Thank you. See if we have some community questions. How many clinicians taught the classes? And if it was more than one, did you assess data based on who the clinician was that was giving the presentation?
All right, so with the Thank you so much for the question. With the classes, there's only one clinician, and that was me. It was a 1-hour lecture that I did for about 5 classes at a local high school, and I just took surveys before and after that. And
Great, thank you. So this is great, very interesting study. And are there currently other sex education interventions run by family medicine providers that you were able to find in the research or literature?
okay. So before I started my program, I did about a systematic literature review. I looked over about 40 studies, and I only found one that was ran by a, not even a family medicine provider, but by a clinician. And that was run by a gynecologist, and she was in the control group. And this other study I found was run by a nurse practitioner. And most of them, they were run by PhD students, people in the community, and teachers as well from my literature review.
Thank you. Thank you very much. Our next presenter is Dennis Wu from UC Riverside School of Medicine, Family Medicine Residency Program in Palm Springs.
My name is Dennis Wu. It's nice to meet everyone. So I'll be presenting a case tonight on beta blocker toxicity. Next slide. So on October 18th, we had a 58-year-old woman who was brought in by ambulance for altered mental status. Chart review showed her past medical history of depression and hypertension. On the left column in the rectangular box, she was normothermic, bradycardic to 57, and hypotensive. She was altered with a GCS of 13, and white blood cell and lactic acid were mildly elevated. Her urine screen was negative, and her alcohol was approximately 3 times the legal limit. But based on her presentation, she was presumed to be septic, and she met 2 of 3 Q-SOAP criteria, which is highlighted by asterisk. Moving to the middle column, she was given the appropriate amount of IV fluids and broad-spectrum antibiotics, but she remained hemodynamically unstable and altered. The lack of a clear source of infection, no fever, and bradycardia were inconsistent with sepsis, so we evaluated the patient. And on further interview, she admitted to overdosing on her home metoprolol, which later came out to approximately 2 grams. In the right column, she received 1 milligram of glucagon, and she responded within minutes with heart rate correcting to 75 and BP stabilizing to 114/75. Her lab abnormality is also corrected, and she was ready for discharge after overnight observation. Next slide. So severe cases of beta blocker overdose have tripled since the year 2000, which is when the American Association of Poison Control Centers first began tracking cases. This is due to the fact that over 70 million beta blocker prescriptions were filled by Medicare and Medicaid patients alone in 2017, making beta blockers the second most commonly double-dose home medication, as well as the second most common cause of adverse drug events after cough and ACE inhibitors. It is important to have a strong clinical suspicion of beta blocker overdose because symptoms are non-specific and there is no drug assay available for detection. So in the hospital setting, mild cases of beta blocker overdose usually respond pretty well to IV fluids and atropine, but more severe cases require glucagon to prevent decompensation and potential ICU admission. Now, there's no dispute that beta blockers have revolutionized the treatment of cardiovascular disease by reducing mortality from stroke and heart attack by 30%. But their prevalence and narrow therapeutic index have made side effects commonplace. So because of this, it is important to routinely screen for side effects in patients on beta blockers in order to titrate them.
Dennis, great job. You reached time.
Thank you.
Thank you, Dennis. We'll pause for some questions from the community. Here's a question for you, Dennis. In this patient with altered mental status and hypertension, was stroke considered in the differential diagnosis? And was there a thought to check the CT head initially?
Yeah, so in this patient, the differential was pretty wide, especially because aside from the vital signs, pretty much a lot of our labs were really non-specific. So she was considered for stroke initially, and the CT head was negative, but we didn't have a super strong suspicion of stroke because she didn't have any of the asymmetric features or dysarthria or anything. She just sounded drunk more than dysarthric.
Thank you. We have a question from Carol Havens. And was this an unintentional overdose or a deliberate overdose of the medication?
So at the time we didn't know, but we had a social work consult made, and it was later determined that she had intentionally overdosed on this medication. Thankfully, she had only used alcohol and metoprolol. Most cases of death from beta blockers have a co-ingestion, usually with calcium channel blockers. And thankfully, she was fairly healthy and didn't have a lot of other medications to take at home.
Thank you. Okay, excellent. So we will move on to our next presenter, Tu Nguyen from Pomona Valley Hospital Family Medicine Residency Program.
Hi, I would like to talk about our research project, Universal Screening for Gonorrhea and Chlamydia in female patients aged 15 to 24. So CDC and USPSTF recommend screening only sexually active women aged less than 25 years old or older women who have higher risk. But some of the patients at our clinic have positive test results even though they wasn't documented as being sexually active in the chart. That's why we decided to study the effectiveness of universal screening of all the female patients. So these are retrospective cohort study. We educated the resident and the attending through meeting, emails, and workshop about obtaining sexually history and screening as well as treating for the STD. So we recorded the percentage of each category before and after the intervention. So for the result, we didn't find much of the difference between the before and the after of the intervention. The Kaiway stat revealed no significant association between sexual activity documentation and positive result of gonorrhea and chlamydia. Less than 50% of patients are documented in our clinic to be sexually active, compared to CDC report data of 55% adolescents less than 18 have sex. So many barriers exist for universal screening, such as documenting the sexual history, provider, patient, parent comfort, and stigma, as well as time and confidentiality. So additional education and a standardized workflow may help improve the history taking and screening. A larger sample size would also needed to be able to add additional analysis cost for the cost effectiveness of the study.
Great job. You've reached time.
Thank you.
Thank you, too. So here's a question. Please clarify what method you used to screen the 371 patients. Were they all visits in that age group, well child, acute visits? And then maybe you could also add to there what testing strategy you used, urine, pap smear, et cetera.
Yeah, so we did the chart review for all like well child acute visit. We did like just acute, yeah, we include all the acute well child visit, and we go back to the chart. We do the chart review to see if the sexual activity was documented, and we check both urine or vaginal swab were tested for you for testing. That's how we did that's how the methods were, and the patients were in our clinic only, with other resident and attending patients included.
Thank you.
Yeah.
I have another question for you. After the intervention, were you able to evaluate the percentage of patients that refused screening or declined?
Yeah, so not specifically patient refuse. We just document either it was documented or not documented. We do not document if patient refuse or the food provider did not document. Yeah.
I understand. Thank you. Thank you too.
Thank you so much.
Okay, great. Now we move on to two presenters from Eisenhower Medical Center Family Medicine Residency Program, Megan Bakey and Nancy Armaños.
Hello everyone, I'm Nancy Armaños.
And I'm Megan Bakey.
We're presenting, oh, next slide please. We're presenting a case of a 63-year-old male with well-controlled type 2 diabetes, hypertension, and hyperlipidemia. He presented with complaints of swelling of his face and after sustaining over 100 bee stings. On arrival, vitals were stable. Physical exam was significant only for facial swelling. 2 hours after admission, his daughter noted slurring of his speech and slight facial droop. Neuroexam was relatively unremarkable. He had a questionable left facial droop that was attributed to the swelling. Stat CT was negative at that time. 12 hours later, a rapid response was called. Exam showed a left pupil dilatation with a GCS of 7. Stat MRI brain was ordered and showed multiple acute infarcts as seen below. At this point, he was outside the TPA window. He was then intubated due to encephalopathy. Next slide, please.
Interestingly enough, there are only 7 documented cases describing a pro-inflammatory state after bee stings, ultimately leading to stroke. There are 2 potential pathophysiologic mechanisms. One involves hypotension in the setting of anaphylactic shock, which causes cerebral ischemia, not the case in our patient. Second involves vasoconstriction and a prothrombotic state. In response to high amounts of bee venom, our bodies release inflammatory mediators that ultimately cause vasoconstriction. This vasoconstriction can then be aggravated by exogenous epinephrine administration, therefore increasing our risk of stroke. Also, wasp venom contains thrombogenic and allergenic peptides that lead to an immune-mediated IgE reaction and platelet aggregation. So we think it's important for family physicians to be aware of this, as proper management may include timely control of inflammation. Looking back on our patient, would he have benefited from an IV prolonged steroid course to limit inflammatory response, or maybe early aspirin to limit thrombus formation? It's difficult to say. We hope you all found this as interesting as we did, and we hope that physicians will now be more aware of this rare link between the high burden of bee venom and ischemic stroke. Next slide, please.
And you're at time.
Perfect.
Thank you.
You knew it. Excellent. And we already have a question for you too. So, was he stung by Africanized bees, and was there any discussion of case reports for regular versus Africanized bee stings as being more risky for stroke?
So our patient was, he was at work as a gardener, trimming trees around the local area. I'm not perfectly sure if it was Africanized bees or not, but he was trimming a tree, and it was one beehive that when he trimmed the tree, and it was, over 100 bee stings. It was multiple.
We do think it was more wasp related as opposed to bee related, just because the venom in each of the 2 are a little bit different and do create, the venom in the wasp has a lot of different properties that more so cause a stronger immune reaction, and therefore, would likely contribute to more of his symptoms.
Very interesting. And there's another question. How's this patient doing now?
So the patient returned to the hospital 3 months later with urosepsis that we suspect is from a neurogenic bladder, because when he left, he was still nonverbal, had residual right hemiplegia. So when he returned, he had urosepsis, and unfortunately he passed away.
Oh my goodness.
Yeah, before we actually discharged him, he was dysphagic, he couldn't eat, obviously, so we had to put a G-tube in, and then he also had that neurogenic bladder, so he left with a Foley, and then ultimately when he came back, he succumbed to urosepsis. So it was a sad case, but interesting.
Yeah. There was one other question up, but I think you answered it. He was not a beekeeper, but he was a landscaper, right? Or a
Correct.
tree trimmer. And just happened on a hive of bees.
Unfortunately, yeah.
Oh my goodness. Yeah. Okay. Thank you.
Thank you.
Thank you.
Okay, our next presenter is Vasily Rosenbaum from Eisenhower Medical Center Family Medicine Residency Program. He'll be presenting. Other collaborators on the project were Anna Ascari and Charles Lee. Thank you.
Hello, our presentation is on dietary sugar in a California public high school. Are we contributing to lifelong obesity? Next slide. The standard American school diet is heavily concentrated around processed sugars, the primary driver of obesity among children. The Coachella Valley has among the highest rates of childhood obesity in the state of California. Unfortunately, the federal school meal program is based on outdated nutritional recommendations. The 2015 WHO's nutritional guidelines set the limit at 50 grams of free sugars per day based on a 2,000 calorie daily diet. According to the WHO, the term free sugars refers to all monosaccharides and disaccharides added to foods by the manufacturer, cook, or consumer plus the sugars that are naturally present in honey, syrups, and fruit juices. After investigating a Coachella Valley High School, we hypothesized that children are being fed excess calories in the form of processed foods, which mostly consist of excess free sugars. Our data over a 5-day school week in January 2018 shows that a typical high school student receives on average 230 grams of carbohydrates per day as represented by the light blue lines. Of that, at least 65% of the carbohydrates are comprised of free sugars as represented by the red lines. As you can see in our next slide, we've calculated this as nearly 61 pounds of sugar in a single school year. During a student's 4 years in high school, a student would consume in excess of 244 pounds of sugar. Consequently, obesity among children in the Coachella Valley is nearly double that of the national average. We've concluded that this diet promotes weight gain and eating patterns that subsequently predispose children to a lifetime struggle of obesity-related diseases. That's it. Next slide.
Great.
Thank you very much.
You're under time.
Yes.
Yay.
Excellent. Well, those bags of sugar were quite something.
Yeah.
Here's a question. Since your study included breakfast, lunch, and snacks, what percentage of sugar came from each type of meal or snack? Where would you start your intervention first if you were working with the school district?
So I would say that most of the sugars are essentially pretty much comparable in breakfast, lunch, and the afternoon school snack. I wouldn't specifically target a specific area. I would actually try to take the whole school meal program down, because most of these kids have financial limitations, and therefore their only form of food is what they receive at school. And these school meals are approximately 1,800 calories per day. And the schools that have a higher percentage of free and reduced school meal program participants have the highest percentage of obesity, regardless of physical education programs that are available and enforced. So in terms of, attacking either breakfast, lunch, or afternoon school snack, I would just attack the whole thing.
Okay, we have another question from Carol Havens. Was this information given to the school district, and what might be the next steps?
No, not yet. We're kind of trying to take this one step at a time, trying to get this out to the public, maybe through CAFP, like this conference, and then possibly doing a research study with IRB approval. And then we also recently just submitted to the AHA conference, and we did a presentation there. So we're kind of getting the word out slowly, but trying to work through this one step at a time.
Thank you.
Yeah.
Great. And now I'm happy to introduce Elizabeth Sophie from UCSD Family Medicine Residency Program.
Thanks, Dr. McGinnis. Thanks, everyone. We'll wrap it up here. A case of premature thelarchy that I saw in my clinic. Next slide, please. So this was the case of a 2-year-old and 5-month-old female. She came into clinic for a check with her parents, presenting with premature thelarchy, which by definition refers to isolated breast development before age 3. And it's kind of categorized into central, peripheral, or benign etiologies based on different workups and other symptoms that are associated. So for our patient, she had, for the past few months, bilateral breast growth without any other concerning symptoms of any other signs of increased hormones. Her exam vitals were normal other than her bilateral breast development. She had had an unremarkable and non-contributory family history, as well as past medical history, including her birth history. So for our initial diagnosis for her, we were concerned about premature thelarchy, but needed to rule out precocious puberty, either central or peripheral. She got labs and imaging, including hormones and a bone age study, which were all normal. So we kind of went back to the parents, to the drawing board, asked if they had any known exposures to lavender, tea tree, or essential oils. They denied it. However, going home, when they ended up looking at some of the products they had been using for the patient, they were using those products down in the corner, which contained lavender. So her final diagnosis was premature thelarchy, which is a form of benign or non-progressive precocious puberty, secondary to lavender exposure in this case. Next slide, please. So for this discussion, I think it's really important as a family physician to recognize that lavender is really common in some of the home and hygiene products we use, not only in our pediatric patients, but in our patients of all ages. And there have been some studies showing that both lavender and tea tree oil in products can cause prepubertal gynecomastia in males, as well as premature theolarchy in females in the setting of an otherwise normal patient. There's some studies that have done looked at human cell lines and the topical application of these products as well, and seen some upregulation in the different DNA segments and kind of the transcription factors. And so,
Elizabeth, you've reached time.
It's important to know that.
Thank you.
Yeah.
I certainly learned something by reading this and hearing your presentation. What were the parents? What were the parents using the over-the-counter products for on this child? And was there any kind of a cultural or family background to the use of these products?
So the family is a upper middle class family. They live in San Diego. One parent is a baker, one works in research. They had no religious or any other reason to be using lavender products other than they kind of had an interest in like alternative and natural things. If you look on the slide, they had a few products. They were using hand soap, which was for all parties in the house, and then specifically for their daughter, they had been using some lotion, like nighttime lotion, and then some wipes. Not all of the diaper wipes, but some wipes that they were using besides the lotion.
Interesting. I was wondering what recommendations that you would make for patients. Is there a known limit to exposure or recommendations that are being made for infants or young children?
Yes, this is a really interesting question, because if you think about how many of our patients are using this, and now that we're like in a big time of stress, more and more people are kind of leaning towards things that they can get more easily in the store or whatever, online and Amazon. There's not any data in terms of the concentration, and it would also kind of depend on the baseline hormones that the child would have. So there's no way to sort of quantify it. What we have now been telling people in my clinic is if you're using it, just be aware. It reverses and there's no long-term effects, but just kind of educating people, and then kind of educating the parents as well for themselves, because that could have some effects for some of our obese patients and other people who have a high estrogen exposure anyway.
Thank you. Well, wow, this is, guys were all amazing. Absolutely, congratulations to all of our residents. And thank you for sharing this really excellent work with us. Very interesting, thought-provoking. And I encourage everyone to visit all of the online posters. They can all be viewed thanks to Josh and his virtual exhibit hall at familydocs.org resident poster contest. So really encourage people. So, my goodness, all right. These scores are already in. As I said, everyone, and just by being here presenting fascinating work, everyone wins, but we will announce a specific winner. And we announce for the case presentation, we have the winner, Dr. Sophie, this fascinating case of lavender exposure, which probably was a little bit new for all of us. So congratulations.
Thank you.
Very, very interesting. Here's a few fireworks for you. And I'm ready to give you all a big round of applause here soon. And we have a research winner as well for the very interesting study with a lot of implications, I think, for our California population. The research winner is Dr. Fredrickson. Congratulations. Yay. Here's my bravo. Really, really great. I definitely just encourage all of you to continue on this pathway of inquiry, of clinical curiosity. You're just by participating, by thinking through these cases, these studies, You're going to be leaders in family medicine. All of the topics are so important to the future, both of family medicine, but more importantly to the future of the health of our community, of the health of our population in California. I really love the breadth of topics, the really applicable studies that are important in a public health sense, reproductive health sense, really excellent. And the cases just shows you that, you know, when students say, oh, you know, do you see anything interesting in family medicine? I mean, just the cases that are presented here are so representative of how broad we have to keep our minds and our differential when we're seeing patients in family medicine. So I just can't congratulate you enough. Excellent work. Thank you. Thank you for participating.
Great. Thank you, Marianne, and thank you to all the residents. Just to close it out, we just want to say one more thank you to all of you who joined us on the live stream and those who submitted questions. And if you're a resident on the line, consider participating in the poster contest next year. We hope to do this in person at the clinical forum. But yeah, thank you for joining us online. This was a great experience. And we'll see you next week, next Sunday, for our next community conversation. So have a great night, everyone.
Thank you.
Thank you.
Thank you.
All right, thank you.
Thank you.
Good night, all. Great job.
Thank you. Thank you.
Terrific job.
It's good.
Really great. Really great.
Really good.
Yeah. Oh, whoops.
Hi, Lauren.
Lost my